Hello. Today I'll be narrating the Emory Community Health Needs Assessment Evaluation, or CHNA, done by Alexandra Irwin, Nia Fowler, Hannah Lancaster, and Madison Smith. To start off, just a brief general overview of Emory Hospital. It's located in Atlanta, Georgia, specifically DeKalb County. Its population is a diverse urban and suburban community, and the year the CHNA was completed was in 2022. Priority health needs identified were aging-related issues, mental health, chronic disease such as diabetes, cardiovascular disease, hypertension, and cancer risks. The contributing factors were violence, substance abuse, and limited affordable health care. The CHNA criteria. Each criterion will have an evaluation as well as feedback. The evaluation scale goes as follows from lowest to highest: low, partial, moderate, good, and high. To start off, definition of community, we found good detail. Service area was well defined by county and demographics. Stakeholder involvement, moderate detail. Community partners were listed but limited to resident voice, and we'll get into this later. Organizational structure, good detail. The CHNA planning team was identified through the system leadership. Assets and resources, moderate detail. Hospitals, clinics, and outreach were noted, but they could list more community organizations. Clear goals and objectives, partial detail. Strategies were named, but outcomes were not always measurable. CHNA description, high detail, uses public health data as well as county health rankings. Feasibility and sustainability, moderate detail. The strategies they listed were realistic, but they all depend on grants and staffing. Evaluation and monitoring plan, low detail. Limited explanation of how success will be measured. Accessibility of CHNA, we listed this as a high detail because the CHNA is available online, it's readable and publicly accessible. For an in-depth review of key criteria, quantitative data on page 3. Centers for Disease Control and Prevention listed data points on health statistics and informational facts and figures. Strengths, leading authority on health and disease in the United States. Limitations, used as a national comparator instead of a local comparator. The Department of Health and Human Services, Healthy People. Goals provided were every 10 years to improve national health. Strengths, provides national benchmarks for health. Limitations, use the CHNA to provide more background data than data that is actually actionable. The Georgia Department of Public Health, OASIS. It's a county level mortality statistics for the state of Georgia. Strengths, the data that was given was location specific and includes race and ethnicity. Its limitations, data that was based on income was not available. IBM Watson Health, location-specific demographic data. Strengths gave variety of data points which were sometimes available. Limitations, an aggregate database from other sources. This limits reporting capabilities. NCI Surveillance, Epidemiology, and End Result Program, data on cancer cases. Strengths, provides cancer statistics at the state level. Limitations, provides aggregate data from various sources which potentially limits the standardization. National Institute for Mental Health, mental health statistics. Strengths, leads federal agency for research on mental disorders. Limitations, they were unclear on specifics for data collected. National Institute on Drug Abuse gave drug abuse statistics, strengths, research on causes and consequences of drug use and addiction, limitations. Again, they were unclear about specifics on the data collected, just like the National Institute for Mental Health. Robert Wood Johnson Foundation and the University of Wisconsin's Community Health Rankings and Roadmaps gave health overview at the state and county level. Strengths. The data is location specific and compares data locally versus nationally. Limitations. Aggregate data from other sources limits reporting capabilities, as well as the data does not include race, ethnicity, or income. The United States Bureau of Labor Statistics gave unemployment data. Strengths. The statistics based on the most recent month and year, which would have been December 2021. The data provided is location specific, and there were no limitations. The United Health Foundation's America's Health Rankings gave an overview of each state's health. Strengths. The state level prevalence and incidence of multiple population health topics. Limitations. The data does not include race, ethnicity, or income and compares state level data to national level data. The biggest issue we found with this quantitative data and the resources that they found for the CHNA was that a lot of this data was aggregate and it was not specific to the local area of DeKalb County or Georgia in general. Identification of issues from quantitative data analysis, which can be found on page 10 through 15. Obesity, smoking and tobacco use, cardiovascular and heart disease, diabetes, COVID-19, cancer, respiratory disease, neurological disorders and diseases, chronic kidney disease, mental health, maternal and child health, substance abuse, and sexually transmitted diseases. In-depth review of key criteria, qualitative data, which can be found on page 3 and page 87. The method that Emory Hospital used was an online survey. The respondents include stakeholders from community organizations such as faith-based communities, civic organizations, employers, government, healthcare providers, and other nonprofit organizations. The datasets and analysis performed by race and age, gave perceptions of community health, perceptions of top health issues, perceptions of top behavioral issues impacting the community's health, perceptions of environmental impacts on community health, as well as perceived barriers to healthcare access. The strengths was that it gave a variety of community organizations as respondents, and the data can be analyzed by race and age to explore trends in the community priorities. Also, the community perceptions can highlight gaps that providers may be blind to or they do not see regularly. Limitations. The online survey may limit respondents due to access, comfort level with technology, and only includes members of the community who are part of these community organizations. So, for example, it may limit the elderly or in general, people who have limited access to the internet because of the use with technology, as well as other members of the community who are not a part of these community organizations. Identification of issues from qualitative data analysis, found on page 18. Mental health, aging issues, obesity and being overweight, high blood pressure, addiction and substance abuse, diabetes, cardiovascular diseases, cancer, violence, and COVID-19. These were a brief overview that came from the survey. However, they did not explain how they came up with the focus topics due from the qualitative data. In-depth review of key criteria, the data evaluation. Lacking other important socioeconomic data sets that affect the population health, such as population with limited English proficiency, housing quality of the service areas, and households with no motor vehicle. It focused mostly on national comparators versus outcomes of previous year's CHNA outcomes achieved, such as the one done in 2019. However, a brief summary of review of the previous CHNAs were found in the appendix. Prioritize needs, which can be found on page 1 of the implementation plan, stated issues related to aging, mental health, cancer, cardiovascular diseases, and related risk factors such as obesity, high blood pressure, and diabetes. Process for prioritizing needs based on identification from qualitative and quantitative data analysis were not explicitly stated. The first prioritized need, mental health, causes and contributing influences were crime and violence, substance abuse and addiction, and access and affordability of healthcare. Their strategy and action plan was to improve healthcare access. Their intervention, expand our behavioral health unit and add outpatient resources, which can be found on page 2 of the implementation plan. It should be stated that evidence for this intervention was not explicitly stated or explained. Consideration of local context. Georgia ranked 35th out of the 50 states for adults reporting frequent mental distress. Georgia ranked fourth worst in the United States on the number of mental health providers per 100,000. To address the prioritized need of mental health, increasing the number of mental health providers per 100,000 is desperately needed in this community. Social determinants of health addressed with this intervention were lack of access to healthcare, challenging neighborhood and physical environments, community and social context. Prioritized need number 2, cancer, cardiovascular diseases, and related risk factors such as obesity, high blood pressure, and diabetes. Causes and contributing influences were crime and violence, substance abuse and addiction, access and affordability of healthcare. Strategy and action plan, disease prevention and chronic disease management. Their intervention, enhance inpatient and community education to address chronic issues including obesity, cardiovascular disease, hypertension, and kidney failure, which can be found on page 2 of the implementation plan. Again, the evidence for this intervention was not explicitly stated or explained. Consideration of local context. The percentage of obese adults in each serviceable county ranged from 25 to 37%. Georgia ranked 31st out of 50 states for cardiovascular diseases. The percentage of adults reporting high blood pressure in the serviceable area is approximately 32%. The percentage of adults reporting being told that they have weak or failing kidneys by a medical professional in the serviceable area is over 2%. It should be noted that as many as 9 out of 10 people who have CKD are unaware that they have it. Social determinants of health addressed with this intervention were lack of access to healthcare, educational gaps, community and social context. Mental health intervention. Expand behavioral unit and add outpatient resources, which can be found on page 2 of the implementation plan, was their aim. It was very broad and could include better evidence-based practices within the overall plan. It serves the overall population surrounding Emory Hospital. Although it is a tertiary intervention, it does improve access to care and geographic reach of mental health programs, targeting health disparities in the area. The expansion of these programs is likely to show measurable improvements of care, but more specific intervention plans are needed to determine the outcomes. Focus community education on the following priority topics: mental health, which can be found on page 3 of the implementation plan. Community education could include many evidence-based practices, although more details are needed. Serves the overall population, including underserved populations in the surrounding areas. Can work at the primary or tertiary level depending on the focus of mental health education, such as seeing the signs versus seeing the resources for those affected. Mental health education reduces health disparities by providing resources, reducing stigma, and improves early detection of mental health diagnosis. Education provides measurable improvements in seeking mental health treatments and identifying at-risk individuals. Mental health intervention, evidence-based practice recommendation. We recommend a specific population-based approach aimed at educating the public on mental health concerns because it's needed within the community. High school-based mental health literacy program or curriculum guide. This program aims to teach high school students about mental health by trained teachers over the course of a few weeks. It focuses on understanding mental health, mental disorders, stigma, and resources available to those in need. Here you can find a link taking you directly to the article that we used. Cancer, cardiovascular disease, and related risk factors such as obesity, high blood pressure, diabetes intervention. Their aim was to enhance inpatient and community education to address chronic issues including obesity, cardiovascular disease, hypertension, and kidney failure. This can be found on page 2 of the implementation plan. Education on these topics follows evidence-based practice plans and is widely recognized. The strength of this intervention depends on the specific plans and methods to implement education, such as mobile clinics, screenings, discussions, etc. Primary driver of health literacy is addressed, but not addressed are access to nutritional foods and ability to exercise, which are two of the most important primary drivers. Inpatient education is a method of tertiary prevention, while community-focused education can be primary, occurring before chronic disease. Inpatient and community education has evidence to prove measurable outcomes in disease reduction and prevention. However, more thought-out implementation plans should be designed to predict the outcome. Cancer, cardiovascular disease, and related risk factors such as obesity, high blood pressure, and diabetes intervention. Evidence-based practice recommendation. Our evidence-based practice recommendation is a cancer prevention education campaign. This intervention aligns with enhancing education of chronic diseases with a specific focus on prevalent cancers. This can include risks of tobacco use, sun protection, HPV vaccination, lifestyle changes, etc. Implementation in local school systems should be taught by trained teachers and coaches to give proper education. Evidence of these campaigns show an improvement in cancer screenings and a decrease in risk behavior. Here you can also find the article that we used to come up with this evidence-based practice recommendation. This cancer prevention education campaign would be a great evidence-based practice recommendation, specifically because it can help reduce recurrence risk as well as risk for other chronic diseases that we've mentioned. To finish, this hospital does have plans in place to measurably improve their community health. However, they do not provide detailed evidence-based solutions for how they will achieve their goal. Many of their data sets that they used were aggregate and not specific for DeKalb County or the Georgia area in general. However, they did seem to have very good community perception, which can help them in the long run. Thank you.